let's talk about heart failure. So the first thing I want to talk about is, so you don't go directly into heart failure, right? So you first get systolic or diastolic dysfunction, right? So this dysfunction will eventually lead to heart failure. But we want to talk about this process, right? Because by the time the patients come in, a 65-year-old male, they come in and their hearts, they've been through systolic, diastolic dysfunction. And what was this process over the past 20 years that exactly happened? As we know, the body has this amazing way of compensating for all of these pathological deficits we develop, right? So that's why by the time your patient comes in and they're symptomatic, their heart functions down to, their ejection fraction's down to 20%, or their renal perfusion or their GFR is down to 20%. That's just because the body has great ways of compensating. But it means by the time you get symptomatic, you're usually in a later stage of the disease. So we want to define systolic dysfunction and diastolic dysfunction before we become symptomatic. By the time you become symptomatic, then technically you're in heart failure. So what's the process, right? So typically what happens is we're going to go into systolic failure first, okay? The systolic dysfunction first, not failure. So what does that mean? What does systole mean? That is ejection, right? This is your pump, right? That is when the ventricle squeezes and all the blood goes out of the ventricle, right? So this is by definition pump failure. Can you properly get blood into the ventricle? Yeah, you're good at that point. But the systolic dysfunction is a problem with the pump, okay? So what typically happens that's gonna cause this? Well, at least in the US, MIs, right? If you have some sort of myocardial infarction, if you have a heart attack, some of that tissue is going to die, right? And by definition, if the tissue that is acting as the pump dies, you're going to go into systolic dysfunction, eventually maybe even systolic heart failure. So when you hear systolic dysfunction, I want you to think of pump failure. Now, what are some other causes that can lead to this systolic dysfunction? Well, what if we had long-standing hypertension? Or even, let's use aortic stenosis, okay? We'll just make a caveat real quick. I just want to point this out. Here's a trick I always use. If they ever give you a patient that's like 70 plus years old, I always think aortic stenosis first, okay? And that's just because age-related calcification of that aortic valve is like super prominent. So if you ever see a 70-plus-year-old patient in a question, think aortic stenosis. Okay, now let's get back to it, right? So now, what are we talking about with hypertension and aortic stenosis? We're talking at a very much elevated afterload, right? So hypertension, the pump has to squeeze against all of that systemic vasoconstriction, right? You're blowing through a very narrow straw, right? Aortic stenosis is a stenotic valve. Again, you're trying to pump through a very narrow opening. So again, the pump is going to start to fail, right? If either you have some sort of MI that causes the myocardial damage, so the pump's not strong enough, or you're just having to work so hard that against this high afterload that eventually it's going to have dysfunction and lead to failure. Now, so what happens at this point? At this point, we're going to have a backlog of blood into the ventricle, okay? So that means we're going to have an increased end diastolic volume, okay? So what am I saying? I'm saying that the pump has begun to fail. You're squeezing so much that, and it's failing, so that blood that is supposed to go out of the ventricle is staying in the ventricle, okay? So sometimes they say this pump failure is like the walls are floppy, right? So if you have a myocardial infarction and some of the wall is dead, it gets floppy. But the point is that you can't properly squeeze all of the blood out of the ventricle. So you're going to get increased blood left over. After systole, after that pump ejection, right? So by definition, this is going to just congest that ventricle, and you're going to get an increase in diastolic volume. Okay, so now we have our precursor to what's going on. Now, there's nothing in medicine is black and white. There are grays to everything. Some patients, particularly renal patients that have volume overload, they can go into diastolic dysfunction first. But this is classic, especially in the United States. You're going to go into systolic dysfunction first, typically MI or some sort of longstanding hypertension. Okay, so now what we see is, and this is pretty classic for everyone, at this point, this systolic dysfunction, you're kind of living with it. You're like 5-10 years into your hypertension, like you're fine. But at some point, this end-diastolic volume is going to be a problem, okay? So what you're going to actually end up doing is you're going to try to hypertrophy the ventricle. Why are you doing that? You're trying to make the pump strong again, right? That's your goal. Now, the body's not thinking the long-term consequences of hypertrophying the ventricle. It's saying this pump isn't pumping a lot of blood. We're going to try to hypertrophy the ventricle. We need to make the ventricle thicker so the pump works better. Okay, right. So you're starting to do this. But then what happens, right? Then this ventricle hypertrophied, strong and muscular, it ends up getting stiff, okay? Just because it's a lot of muscle there. So then at this point, you're in trouble because now you're going to go into diastolic dysfunction. And what do we use synonymously for diastole, like where systole was pump failure? This is a filling failure. Okay, so I hope this makes sense to you guys. We went through this process, right? So now we hypertrophied the ventricle becomes stiff. Now, if you have a stiff ventricle, it's not compliant anymore, right? It's not gonna, when you wanna put blood in it, it's not gonna get bigger, right? So you are going to now be in diastolic dysfunction, a filling problem, okay? So maybe you're able to, maybe you were able to compensate a little bit with that hypertrophy by making the pump stronger, but now because you hypertrophied it, you made it stiff, it's not compliant, meaning it's not going to stretch. So now you have a problem filling the ventricle. Okay, so this is the process. Now, in real life, it's not like this linear thing where you go into systolic dysfunction, then go into diastolic dysfunction, then systolic failure, diastolic failure. It kind of happens synonymously, but we know what our primary cause was, right? Our primary cause was this, well, it had MI or hypertension or whatever led to the systolic or pump problem. But you could see the process. By the time this 65-year-old patient comes in with problems breathing and chest pain on exertion, you're already at this point where you're having trouble filling, okay? So this is the whole process of how this works. So make sure you keep in mind these ideas of systole is a pump, systolic is a pump failure, whereas diastolic is going to be a filling failure.